Thank you, Professor Indolfi. Thank you, EPSGAN and Organizing Committee, and good morning to everybody. It's a pleasure to be in Copenhagen with you. I'm delighted to answer the request from the Organizing Committee and speaking about surgical challenges in children with liver disease, from Kasai to liver transplant and beyond. When I started to prepare the talk, I realized quickly that the number of condition and liver disease and the number of challenge was too great to summarize in 30 minutes. So I decided to stick to the title and present mostly biliary atresia, because it will bring us from Kasai to transplant and beyond. Just a few historical landmarks. Biliary atresia is known for 100 years and more. And it has been for very long a great frustration for surgeons, as this was simply a biliary obstruction, basically, and they could not do anything. We had to wait until 1959 for Professor Kasai introducing a new operation for this disease that was considered non-correctable and making the disease curable, even if it was not for every case. And incidentally, it took another 3-4 years for Professor Starzl introducing another possible cure for biliary atresia, which was transplantation. In 1963, he started in open for the first time to the world access to liver transplantation by performing the first human clinical transplantation. And by the way, it was in a child, 3 years of age, a biliary atresia. It took, however, another 30 years to bring this liver transplantation to the state of being available for any child, and especially the very small children with biliary atresia, because liver transplantation was at the beginning designated mostly with big livers, big donors to big recipients. It took many years to get immunosuppression, and in the 80s, the introduction of cyclosporine and then later of tacrolimus, and the introduction by the surgeon of innovative techniques in 89 and 90, which were the split, the liver division, and the living donation. In fact, by the early 90s, 30 years ago, surgeons had all the tools to cure biliary atresia, either with a Kasai operation or with the liver transplantation. So let's see, after 30 years of having everything and every tool, of course, I will not speak very much about all the medicine and medical aspects that pediatricians have been developing during the 30 years, but where are we now? What are the challenges we are facing about biliary atresia? Because for the surgeon operating a child, a small child, or any patient, the first challenge is the success of the operation. And at the end, we also have to make our patient surviving. I will look, the viewpoint on this during the lecture will be the success of the operation and the patient survival. First, let's start with the Kasai operation. There are many aspects that could be considered challenges. In fact, one big challenge, the only big challenge, is not the technical aspect, laparoscopy or no, liver exteriorization or no. The only big challenge we have is achieving the highest rate of bioflow restoration, which is defined as the success of a Kasai operation. This slide summarizes the recent analysis of French registry, the French registry of biliary atresia. Christophe Chardot did the multivariate analysis, and you can see that there are 3 major prognosis factors, which is 1, the anatomical type of biliary atresia. The second, the fact that it is associated to polymer formation and polyspenia in particular. And third, age of operation. And then we come to this dogma that we all know that we should operate and propose the Kasai before the 4th month of life. We all have been educated that 60 days is important, and we are sticking to 60 days. And in fact, this registry shows that if you can operate the child within the first month, there is a big difference. There is more difference operating during the first month and the second month than between the second month and the third month. So we probably must move to earlier, because this has been found not only in France, but in many other registries, England, Canada, Japan, and also in America. When you look at multicentric studies, they bring the same data. Results are much, much better before the age of, before the age of 30 days. Our problem is that in the last 3 decades, since 30 years, we've been evolving and progressing, improving slightly, but we are sticking to the 60 days. In every series for the last 20 years, we found the median age, which is 55, 60 days. And this correlates to an overall survival of the patient, combining Kasai and transplantation, which is sticking to 90%. We did not improve very, very much. This is a summary, a conclusion of a very recent review by a group of experts. It is from this year, and they concluded that delayed disease recognition, late patient referral, and untimely surgery, and this is valid for Kasai but also for liver transplant, remains a worldwide problem. Maximizing the primary success rate of Kasai portal enterostomy, which means achieving by flow, has only one solution if we want to improve, if we want to challenge ourselves. Early suspicion, early diagnosis, early Kasai. By that I mean less than 30 days. And this is not something very new. 30 years ago, Mowat wrote, late referral for biliary atresia equal missed opportunities for effective surgery. And he commented, liver disease should be suspected in any infant jaundice after 14 days of age. Let's see what happened in the last 30 years from that writing from Mowat and the review by Patrick McKiernan about that particular aspect. He concluded that education has not succeeded for a prompt diagnosis of biliary atresia. Time to move to universal screening. Until now, we have been based most of our effort for screening on a large basis on the stool color card. And it has been introduced in Japan. It has been mostly developed on a national basis in Taiwan. And in Taiwan, they have been doing great. I mean, they eliminated the very late Kasai, which means every child had a Kasai and none were going to liver transplantation as a primary operation. They lowered the median age of Kasai below the 60 days, but not below the 30 days. And in fact, they brought from around 70 days median Kasai, median age of Kasai, to around 50, which is great. But is it enough? It is far above the 30 days if we want to achieve the best result for a Kasai operation. And in fact, they are not the only one, because many people, although it has been proved very, very difficult to set up. It took 5 years in Swiss recently to set up a stool color card. I mean, they had many, many problems, and that's a very, very small country. Those who try to use this color card have shown that they have some effect. They can bring the median age a little bit lower, but not as much as we would like or as much as we should do. And some people have shown there are serious limitations in trying to develop such a model, because you need to involve the whole system, the whole health system, and there are many barrages of education, starting by the general practitioner, the pediatrician who are confronted with the families and have seen one biliary atresia in their whole life. I mean, that's a very difficult education step. If the future is our 30 days target, how could we do? Our pivot showed that in biliary atresia patients, in fact, the disease starts for most cases very, very early on. And if you check the conjugated bilirubin after birth, you can see that during the first, the second, the third, and the fourth day, already the levels are pathological. He considered that at 3 days, 60 hours after birth, would be significantly associated with a high level, and he continued developing that idea. And between 2015 and 2018, they were screening in a few hospitals a total of 120,000 newborns in a two-stage model. A first blood test very early after birth before the child goes home, and then they were just calling back some of the children who were positive to recheck them. They found 7 biliary atresia, but the sensitivity and the specificity of this model is nearly 100%. These are the results. Before the screening, median age of Kasai around 60 days. After the screening, there are both population of people who were in the screening and those who were incidental feeding from other hospitals. So you see that, however, the median age of that group is below 30 days. And there are two groups of patients. You see those at the bottom. They are the people who were screened and they were brought to Kasai really during the first months of life. But you see there are 7 other patients who are on the top. And this probably confirmed the validity of this approach, because these 7 patients were those who were coming from other hospitals who were not part of the screening, and those arrived during the second month. So their way of doing is probably excellent. More excellent are the results. During the screening, even if not all the patients were coming very early, you can see that most of the Kasai were done within the first month. The success rate was from 40 pushed to nearly 80%, and the 1-year native liver survival was pushed to 95%. It's not significant, but we would like to all have this type of results. The future is probably, and it is a big challenge, not only for surgeons, but for all of us. The future is a coordinated, multifaceted and universal screening. It will be difficult to set up, but it will also need a rapid response to the positivity and an efficient delivery of care. And by that I mean that will be the part of the surgeon. I know many surgeons consider that if they do the operation within 3 months, that's good. So they would not put them as an urgent child to operate the next day or the next week. They would just wait, because 60 days or 90 days is not very much different. And they may be right, because the only difference is not 60 compared to 90, it's less than 30 compared to anything else. Second challenge, even with the Kasai operation, we don't have only success. 40% at the moment, 40% of the biliary atresia patients need a liver replacement within 5 years of age. 60% overall will need a replacement of the liver within childhood. If we want to approach the liver replacement surgery or liver transplantation, our objective should be to maximize the success rate. We will see why. What are the facts? Nowadays, we know that we have, for the last 2 decades, a plafooning. The outcome is relatively stagnant. We are doing well, much better than in the past. But for 20 years, the results are nearly the same. We have been improving a lot of other things, but not the outcome. We are relatively blocked. We are also relatively stagnant in the pre-transplant mortality. I showed that the post-transplant mortality remains equal. The pre-transplant is contaminated by unnecessary loss of patients, which are dying while they are waiting on the list. For the patients who are dying on the list, the problem is even worse, is that it is targeting specifically the very small. The children who are after Kasai, reaching the age of 2-3 years and need a liver, are usually doing relatively well, and they can wait. The mortality is very low on the waiting list. But as you go less than 2 years, less than 1 year, and more important, less than 6 months of age when they need a liver replacement, you can get up to 10% mortality on the waiting list. That is probably preventable if we find the right way, if we find the way to allocate livers in time. And you can see that many of these children who are waiting on the list, not only deteriorate when they are on the list, but there is another problem we can face and we can solve, is that many of them arrive at assessment with already a very advanced liver disease, characterized in this series, which is treatment of patients in the last 5 years. It is a series 2016 to yesterday. Only children less than 3 years of age at the time they were referred to the transplant center. At arrival in the transplant center, 50% of them already had ascites, and nearly 40% of them had an enteral support for nutrition, which means they were quite advanced. Should we wait as long to refer the patient for the only last operation they can have and survive with? Probably a little bit. We can do better. Can we do better? Yes, we can. Maximizing the overall success rate of transplantation is multifactorial, and we need everything of this list. Early prediction of Kasai failure in order to refer earlier in time to the transplant center. Keeping the child in optimal condition and making their wait a little bit less longer. And then work of the surgeon, decreasing the technical complication rate and the mortality of children after transplantation. And last, in the follow-up, preventing secondary failure. We'll go first to optimal condition at transplantation. We know that the child who is waiting in ITU in bad condition, receiving a liver, when he's doing not so well in intensive care, is doing much less good than the one who is waiting at home. And you can see that this number shows that from European Liver Transplant Registry, we can see that for the children who are waiting in ITU, there is a 20% less good outcome compared to the patient who are waiting at home. And for those who are waiting in hospital, the outcome is just the half, 10% less. At 10 years, there is still a difference of 15%. What's important is that this slide you already have seen, patients arrive quite late at assessment, and we know they have to wait. They have to wait even for a living donor done rapidly. You have to wait a few days, a few weeks. Many children who are waiting for a deceased donor, they wait many weeks, months. And at the time of transplantation, in that setting, 50% of the children are in hospital or in ICU at the time they are called for transplantation, at the time they receive the transplantation. Can we avoid that? Yes, we could, but we have to work for it. We can reduce the waiting time, but also we can send the children earlier on the list. There are many ways to deal with that. I will not go into that at the moment, but we should do better. I remember that these numbers are from a study that we have done very recently. These are children who have been in hospital or assessed for transplantation in the last 5 years. I'm not speaking about 20 years ago. This is the current situation. 50% of the children arrive in the hands of the surgeon the day of transplantation in a condition that is preventable and that we must improve in the future. Timely transplant means early diagnosis of failed Kasai. I will not speak about that, but there are some groups that are trying to predict the failure of the Kasai very early on. We know that within a few weeks we cannot assess only the bilirubin. We need scoring system. We need to anticipate the bad outcome after a Kasai. This is a work. This is another challenge, mostly for pediatricians, but that will help the surgeon to receive the patient timely in their center. For the surgeon, there is also much to do. We have to reduce waiting time because waiting time equals clinical deterioration. And this means allocating graft in time. These two slides summarize the situation in the last 20 years from the European Liver Transplant Registry. And you see that the type of graft we have used, not by choice, because these are the grafts we are proposed. You know that the deceased donation has been characterized by a drop in the number of pediatric donors, and that's something good, but for the transplant surgeon, that's not helping. We need to use more and more alternative grafts. We cannot use full-size liver, so we go for reduced liver, split graft. Split graft has been expanded very much during the last 20 years, but at the moment it is less and less available because the donors are older. We have more steatotic donors. We have more, not brain death, but cardiac death donors. These are difficult to use in children because we have to combine a difficult donor, then a split, and then a transplant. This increases the risk for the recipient and for the transplant itself. And not by surprise, in the pediatric setting, what we see is that progressively in the last 20 years, the living donor option has been slowly increasing and nowadays represent the largest single type of graft as a type that we can offer to children. And it's likely that it will continue to develop. Why? Because the living donor allows to bypass the waiting time. It allows to transplant relatively quickly. And the last meta-analysis showed that it provides superior patient and graft survival outcome compared to the deceased donation. So it's likely that centers who can afford to procure from living donors will continue doing that more and more. Second and last, decreasing technical complication. We know that in the past it was worse, but nowadays we still have to pay a lot of graft loss during the first 2 or 3 months. 15% early graft loss If we could eliminate that part, we would increase the outcome by 10–15% at the long term. So this is something we can target easily because there's a technical complication. You can see that of all graft clots in European liver transplant registry, most of them, 2/3, occur during the first year. And within the first year, the large proportion is within the first month. Why? Because most of this graft loss is caused by vascular problem, thrombosis of the artery, and primary non-function. But many primary non-function, in fact, are not recognized vascular problem. Can we do better? Yes, surgeon can do better. Sorry for that. Come back. This is a good example of a rational approach performed in America, where all the centers combined together try to face this problem of hepatic artery thrombosis. And what they did first is they checked the rate of thrombosis in all centers. And you can see that some centers, a few ones, do very good. They are really the high-performing centers, and they reach 1–2% thrombosis rate, while the mean is 10%, and some centers go up to 20% and more. They designed a roadmap for improvement, which is combining surgical technique, treatment with anticoagulation. And this is another example of, at the level of one center, attention to prevent hepatic artery thrombosis with success. 3 era, an era where they were just doing the standard technique and using a standard dose of heparin. Second era, they introduced a microsurgical technique for the reconstruction of the artery. And the third era, they concentrated more on the medical aspect and customized the anticoagulation, introducing also the use of antithrombin 3. And you can see that they could bring the thrombosis rate from around 10% to less than 2%. And more important, this was associated in the third era with a graft survival, not a patient survival, a graft survival of 93%. This is another publication recent from my team, 126 first consecutive and isolated pediatric liver transplantation, all indication, with the same approach, trying to prevent by any means the thrombosis. In this series, there was no graft loss secondary to vascular thrombosis or primary non-function dysfunction, and the 8-year graft survival, again, was very high, 96%. In conclusion, we've been doing well. We've been with the Kasai bringing a 4-year, 4% survival of the natural history of biliary atresia to 65% at 4 years, only with the Kasai operation. And with the transplant, we have been bringing the overall survival of the patient to 90%. Is that good? Yes, it is good, but that's probably not enough. We know we can increase by doing Kasai earlier. We could move up this bar of 65% to a little bit higher. And we could move the 90% overall survival a little bit higher as well. We have done well, we are getting better, slowly but surely, but there is a lot we can still improve. I come back to this study, 8 pediatric expert centers, America and Europe, very last 5 years of work, concentrating on children less than 3 years at the time they were referred for transplantation. In this group of 220 children, 1 died while waiting, which is excellent. And 6 died after the transplantation, mostly from vascular problem. We can do even better. But look at the results. A lot, more than 1/3 of living donation, which again confirm that this is something we need to accept, to develop. And those who don't like to do the living donor, maybe just referring to centers who can do that, because that's a very important contribution for succeeding and keeping alive the very, very small babies. Overall survival in this group of patients, these are the data of today, nearly 97%. This is another series I published with my team a few years ago. 101 consecutive biliary atresia patients, 99 transplant because 2 patients died before transplant, 1 while he was waiting, 1 while he was assessed. He died from complication before he was even listed, and 1 died after transplantation. And you can see, maybe you have to read the paper, but you can see that The patient who died were the very small, with people more than 15, and they were between 6 and 12 months of age. So if we update that to the current numbers, 137 consecutive biliary atresia patients, 135 transplant, overall survival of the patient who were arriving in the liver transplant center, 98%. It is possible, it can be done. In the best world, with less challenge, for the next talk, we would have universal screening and Kasai by 30 days in most cases, high native liver survival rates. Also, an early scoring and recognition of Kasai failure with preemptive referral for liver transplantation before the child is too sick. If we know he will have to be transplanted, there is no necessity to wait too long. They don't have to be nearly dying to justify a transplantation. If it is part of their program, just let's do it. Elective transplantation, because we would avoid having patient deteriorating too much on the waiting list. Low post-transplant complication rate if the surgeon can achieve it, and overall a very high survival rate, close to 98, 99% for the biliary atresia patient. I've been also proposed to speak beyond, so I go beyond. We have a mission, I think, not only surgeon, but all of us, pediatricians. This is 6 months ago, a publication from the EASL Lancet Commission, and the Commission argues that there should be a fundamental change to prevent the development of advanced liver disease by embracing simple methods, simple but true. And they went into biliary atresia setting, and they said, we need a paradigm shift and a roadmap for future management, better management, a necessary shift in the way in which liver disease needs to be prevented, diagnosed and treated. If we look on our 30 years of management of biliary atresia, it is difficult to find very strong evidence of what we do today. We had no evidence 30 years ago, and there is not very much evidence today. It's a real Tower of Babel. Some would argue for steroid, some other for no steroid. Some say it's important to operate during the first months, and many say no, 60 days is good enough. We use prophylaxis of antibiotics in many ways. I mean, we did not achieve an agreement on nothing, and we do anything and everything the whole day. We are not even able to do commonly the same objective, and everybody goes with his own protocol, which is different from any other. And I agree with the conclusion of this Canadian team, variability of diagnostic approach, surgical technique and medical management is just great. Is it time for standardization? Possibly. We did not prove in 30 years that prophylactic antibiotics is important. We don't know. We don't know about steroids. And nowadays, we don't even know about ursodeoxycholic acid. I mean, we are speaking now the contrary. We still don't know if it is good to give urso to the patient who have no flow after transplantation. Now we say bile acids are bad for the liver, and we treat with IBAT, but we still continue to give urso to those who have no flow. I mean, I don't understand. I'm a surgeon, but I don't understand. I think we need to refine that. There are some people who are now contesting that urso may be important for neonatal jaundice. This is a team from Egypt, and they say that children do better if they are jaundiced as a neonate if they don't receive urso. And in fact, we have no evidence that it is useful, and we have no evidence it is toxic. We don't know. Would like to come because I'm also a surgeon doing hepatobiliary surgery and hepatoblastoma. Hepatoblastoma is not a rare disease. It's a very rare disease. It's 20 times more rare than biliary atresia. And 30 years ago, a group of friends, pediatric surgeon and pediatric oncologist, in a bar designed a study. It took a few years to get to the point of a consensus, but they started 30 years ago in Europe, multicentric study with a single protocol, a single staging, a single strategy. And they multiplied that by 6 different protocols, bringing more and more evidence with time and refining the treatment, going with less and less chemotherapy, more and more effective. And now, after 30 years, they go mondial, world study. They have been able to bring a staging and confirming their staging was strong. They have been implementing new stage and they have been providing more evidence. I mean, if they can do that for hepatoblastoma, which is so rare, just by working together, I think we can do that as well. And Europe has been, with the EASL Commission, challenging the whole community, not only the surgeon, but all of you as well. I would like to quote Professor Vergaard in his sentence, unifying the diversity. The diversity we are, unification we need. Working together and defining more evidence, building evidence, and improving is probably the only way to improve the outcome in the future. Thank you very much.